Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. Today, in continuity with the previous lecture, this is part 2 in stroke. So, in this particular part, we'll be dealing with how you approach to a person who has developed stroke, investigation, treatment part, and localization. So, approach, clinical presentation, localization, investigations and treatment part. So once you make out clinically that person is having a stroke, we have to answer a few questions. One, is patient having neurological problem? If answer is yes, we go to the second part. Which are the CNS structure involved? In that, whether it is upper motor neuron, lower motor neuron, whether person has got any speech disturbances in the form of aphasia, is there any facial involved in the form of upper motor neuron or lower motor neuron? And then after doing that, we should be able to localize where is the lesion. And then with the examination, clinical history, we have to identify whether it is ischemic stroke or hemorrhagic stroke. And again in ischemic, whether it is thrombotic or embolism. And in hemorrhagic, whether it is intracranial hemorrhage or subarachnoid hemorrhage. And then which artery is involved, whether it is anterior cerebral artery, middle cerebral artery, posterior cerebral artery, VB territory, and again in that, whether it is inferior branch in MCA, inferior branch, superior branch, in posterior cerebral artery, whether it is pica, that is posterior inferior cerebral artery, or posterior artery circulations. Now in hemorrhagic stroke, the classical presentation will be severe headache, vomiting, and sudden onset, which progresses very rapidly. Embolic will be abrupt and develops in seconds, while thrombotic develops in minutes and hours, and it will be stroke in evolution, or we also use the word step ladder pattern. And this will be some of the common presentation: facial weakness, unilateral weakness, confusion, speech, dysphagia, visual disturbances, onset of vertigo, numbness, tingling numbness, near syncope, etc. You must be able to differentiate from other condition which mimics like stroke, that is alcohol, uremia, traumatic injury, toxins, infections, post seizures. In this condition, it can mimic, and TIA will develop and will recover completely, and it may last for a few seconds to a minutes, very rarely hours, but never more than 24 hours. Now a person with cerebrovascular stroke, or we call brain accident or brain infarct. The common presentation will be headache, mental change, mental changes means altered mental status in the form of confusion, disorientation, memory impairment, may be associated with aphasia if it is a dominant hemisphere, may have a respiratory problem, cough, decreased swallowing reflex, may have cortical damage, then agnosia, incontinence, may develop even seizures. In TIA, confusion, vertigo, dysarthria, transient hemiparesis, temporary visual disturbances, syncope, etc. are quite common in TIA. A person who develops a hemiplegia or hemiparesis may also have visual disturbances in the form of homonymous hemianopia, or may have even Horner syndrome. Then perception defects, if it is affecting the parietal lobe, hypertension, apraxia, etc. may be there. These are some of the findings which you can get in a cerebrovascular accident, or we call stroke. So sudden numbness, weakness, tingling numbness, severe headache, sudden disturbances in visual disturbances, confusions, difficulty in speaking, aphasia, dizziness, imbalance in coordination, etc. can be the preliminary symptoms. Motor findings like hemiplegia or hemiparesis, communication disturbances in from the dysarthria, aphasia or apraxia, perceptual disturbances in the form of homonymous hemianopia, sensory disturbances in the form of hemiparesis, or even visual disturbances. Cognitive function disturbances may be also there. In case of subarachnoid hemorrhage, particularly very commonly following a hypertensive crisis, or person might have a thunderclap headache, worst headache ever had, altered level of consciousness, nausea, vomiting, photophobia, neck rigidity with Kernig signs and Brugschke sign will favor subarachnoid hemorrhage. Now these are the different lobes involvement, and these are the abnormalities what a person can have. Frontal lobe, person will have difficulty in executing skills, might have even Broca's area affected, can have even anosmia. Primitive reflex will be there, preservation, changes in personality, inability to generate a list, disinhibition. When he gets a parietal lobe involvement, he can have apraxia, neglect, osteognosis, homonymous inferior quadrantic hemianopia, and acalculia. Justman syndrome can be there if there is a dominant parietal lobe involvement, which will include alexia, acalculia, finger agnosia, and right to left disorientation. This will be typical in case of a dominant hemisphere parietal lobe involvement. If temporal lobe is involved, person can have a Wernicke's aphasia, memory impairment, and auditory agnosia, along with homonymous superior quadrantic loss and even the facial agnosia called prosopagnosia. Occipital lobe involvement can be cortical blindness due to damage to visual cortex in the form of homonymous hemianopia. Person can also have a visual agnosia because of a damage to associated areas. This will be the different type of presentation which can be there in case of a cortical damage. Right side brain damage and left side brain damage can produce some typical symptoms. If there is a right side brain damage, you will have an involvement on the left side, like left side hemiplegia or hemiparesis, left side neglect, rapid performance of short attention span, impulsive safety problems, impaired judgment, and impaired time concept. While left side brain damage, right side hemiplegia, impaired speech and language aphasias, particularly Broca's aphasia, because by and large majority of people are right-handed person. Slow performance, impairment in right and left discrimination. Person may have depression, anxiety, and may have even acalculia, agraphia, agnosia, etc. So they always say that left side cerebrovascular stroke can produce right side hemiplegia, impaired speech disturbances, particularly in the form of aphasia, slow performance, homonymous hemianopia, and that will be left cerebral hemisphere. When it is damaged, it will be right side homonymous hemianopia. Person will have depression, anxiety, and also will have acalculia, agraphia, etc. While in case of a right side cerebrovascular stroke, left side hemiplegia, short attention span, visual field defects, particularly left side homonymous hemianopia, then impaired judgment, those will be the common problems. In CT, if you see this type, this is hemorrhage, this is ischemia, or we call infarct. In TIA, one cause of this event, other common causes that will be ruled out, including seizures, migraine aura, and syncope. Less common or possible causes which can mimic like TIA, hypoglycemia, multiple sclerosis, brain tumors, subdural hematoma, etc. should be ruled out. Toxic encephalopathy, those conditions should be ruled out. Any person who comes with a focal arterial ischemia, whether is symptomatic, if answer is yes, more than 24 hours, look for ischemic stroke. If it is less than 24 hours, look for TIA. If answer is no, then it can be silent CNS infarcts. If there is a pathological evidence of infarction, if answer is no, then look for TIA or look for ischemic stroke. If there is an evidence of pathological evidence of infarct, if answer is yes, look for silent infarct or ischemic stroke. Now for localization, there is a basics in stroke, and it is the fourth leading cause of death in USA and the major cause for disability because it leads to residual damage. So you have to differentiate between the two. If you come across this dense opacity, this will be city without contrast. It will immediately rule out hemorrhagic stroke from ischemic stroke. This is typical of hemorrhagic stroke. This is ischemic stroke. So first you have to rule out that. So non-contrast CT will help you to differentiate between ischemic and hemorrhagic stroke, and in TIA you will have neither ischemic or nor hemorrhagic. So if it is ischemic, you can decide regarding giving TPA, and if it is hemorrhagic, you have to avoid giving TPA. So first investigation is to rule out whether it is hemorrhagic or ischemic stroke. And if there is neither ischemia nor hemorrhagic and person recovers completely without any residual damage, it goes in favor of transient ischemic attack. So CT scan showing you where there is no radio or bright shadow, it will be more in favor of ischemic stroke. So you can have a follow-up investigation by flare MRI, which can distinguish a new from old one. So that will be helpful when you want to differentiate between old and new. So this is a simple diagnostic algorithm. If there is an acute focal brain deficit, if answer is no, it is less likely to be stroke. If answer is yes, if it is persistent more than 24 hours, Answer is no, more in favor of TIA. And TIA will show you in CT and MRI, it will be negative. Well, if answer is yes, then CT with high density goes in favor of hemorrhagic stroke, which can be intraparenchymal or subarachnoid. And if it shows a high density shadow in a parenchyma, it is interparenchymal. And in subarachnoid, it is a typical CT picture. If answer is no, it is ischemic stroke. Now you will have to go for EKG and echo to rule out cardioembolism, or you will go for carotid Doppler or MRI angio to find out atherosclerosis and thrombosis, or you can go for CT or MRI scan to find out lacunar infarcts, or you can go for laboratory parameters for finding out coagulopathy, and if none is there, then you will go for cryptogenic stroke. This is a simple algorithm. By investigations, you can come to whether it is cardiogenic or cardioembolic, atherosclerotic and thrombosis, or we call thromboembolic, or lacunar infarcts, or it is vasculopathy or coagulopathy, that is bleeding disorders. So in a neurodiagnostic procedures, you can go for CT initial without contrast, and then if required you can go for CT, MRI, angio. Carotid ultrasound will give you an idea regarding atherosclerotic changes in the carotid artery and thromboembolic phenomena. If there is a cerebral angiogram being done with MR angio, it will give you the best idea regarding a vascular pathophysiology. So, if higher cortical dysfunction, then it goes more in favor of what we call as a total anterior cerebral artery circulation or posterior anterior partial anterior cerebral artery circulation. Hemiparesis either two, partial or total. If answer is no, maybe lacunar infarct or posterior. So if there is an isolated homonymous hemianopia, it is a posterior artery circulation disorders. If there is hemiparesis, maybe lacunar infarct. Ataxic hemiparesis again in favor of lacunar infarct because of involvement of the cerebellar area. Wallenberg syndrome, or we call as a lateral medullary syndromes, if there is a Horner's signs. If there is a hemisensory loss, again it is in favor of lacunar infarcts. If there is a cranial nerve involvement, contralateral motor or sensory involvements, again brainstem strokes. Either it may be Millard-Gubler or Wallenberg syndrome or Weber syndrome. If it is a third cranial nerve, it will be upper part of the midbrain. If it is a Millard-Gubler, it will be a Pons involvement. And if it is a lateral medullary syndrome, it will be a Wallenberg or involvement of medullary part of brainstem. So if there is a circle of Willis involvement, you will have either anterior cerebral artery, middle cerebral artery, posterior cerebral artery or watershed areas. If it is a lacunar infarct, there will be involvement of internal capsule, thalamus, subthalamic nucleus or thalamus plus subthalamic nucleus. If there is a brainstem involvement, anterior inferior cerebellar artery, posterior inferior cerebellar artery or basilar artery involvement. And if it is spinal cord, it is called artery of Adamczewicz, or we call anterior spinal artery. Now, if it is circle of Willis and if it is anterior cerebral artery involvement, lower limb will be more involved. If it is a middle cerebral artery, lower limb will be spared. And if it is a posterior cerebral artery, you will have homonymous hemianopia with macular sparing. And if it is a watershed area, the person will be almost like a locked-in syndrome. So, depending upon the area involvement, in a middle cerebral artery, face will be involved, face and upper arm will be involved. In anterior cerebral artery, lower limb will be involved. And in case of watershed areas, the person will be almost locked in syndrome. And in a posterior cerebral artery, you will have homonymous hemianopia with macular sparing. So leg more involved, anterior cerebral artery, face and arm involved, middle cerebral artery. Always look for this very important differentiation. So these are the four very important differentiation. Now if we come to lacunar infarcts, it can be both together. Internal capsule, it will be more pure motor. If it is thalamus, it will be more sensory. Or it can be combined together where capsule is involved and thalamus is involved. So it can be combination of internal capsule plus thalamus. Then you will have a sensory plus motor. Both will be involved together. So you can have a combination of the two. In anterior basilar artery, you will get locked in syndrome. If you get brainstem involvement, it will be cross damage. You will have a cross pain and temperature loss. It will be anterior inferior cerebellar artery plus pica, that is posterior inferior cerebellar artery. And if there is a spinal cord involvement, will have only vibration spared in the legs. Inner cortical function damage, higher cortex damage. You will have a Wernicke aphasia if temporal lobe is involved. If you have got frontal lobe involved, you will have a Broca's aphasia. If you have parietal lobe involved, you will have a hemi-neglect. You will have apraxia and you will have a agnosia. So this will be the cortical findings because of damage to the cortex. We have already shown you that this is one hemisphere controls the contralateral motor and sensory input. If anterior cerebral artery is involved, and this is middle cerebral artery. If anterior cerebral artery, lower limb is involved. If middle cerebral artery, acute stroke, only the patient lower limb is affected. The lesion has to be in contralateral anterior cerebral artery. Now, if we get leg affected anterior cerebral artery, but if leg is spared, it is more in favor of middle cerebral artery. And you will have face and arm involved. That will be very typical in MCA territory. ACA was this MCA acute stroke presentation. So ACA, lower limb will be involved, weakness and numbness, plus urinary incontinence may be very, very common, and return to primitive reflexes, that is Babinski sign, will be positive. While in a MCA territory, that is left side, right arm, face and numbness, leg spared, and you will have aphasia. While if it is a right side involved, left arm and face will be involved, leg will be spared, and person will have a left-sided hemi-neglect. This will be very typical in case of a MCA territory because of involvement of parietal lobe. So sparing of left or a lower limb will be more in favor of MCA territory, and lower limb involved will be more in favor of ACA territory. We have already mentioned this. Sorry. So again, left side MCA means involvement of the right half of the body. Right arm and face will be involved. Leg spared, aphasia. Very, very common. Because dominant hemisphere is left hemisphere in a right-handed person. And it will be Broca's aphasia. And if you come across a right side middle cerebral artery damage, the person will have a left side weakness, and along with that, because of damage to the parietal lobe, because MCA territory also supplies parietal lobe, you will have a hemi neglect. That will be very, very typical in case of, you can see here, the person has got a hemi neglect of right side. So this will be very, very characteristic. Left side hemi neglect will be there. So this will be very, very typical in a person with right side middle cerebral artery damage. If left side middle cerebral artery superior versus inferior division, because superior division will supply the parietal lobe part, while inferior division will be supplying the frontal lobe area. So Broca's area will be supplied by inferior branch, while Wernicke's area will be supplied by superior branch. So inferior branch will produce, sorry, it should be superior. This will be superior branch. And person will have a Wernicke's aphasia and superior branch here. No. It has to be, this will be inferior branch and this will be the superior branch. Because this is inferior and this is superior. So superior branch will be supplying this area and inferior branch will be supplying this area. There is something wrong here. So you will have a Broca's aphasia. So something is wrong, definitely. This has to be superior branch, this has to be an inferior branch. So Wernicke's aphasia is more with superior branch, while Broca's aphasia is with inferior branch. Something is wrong. Again, along with superior branch, you will have also a quadrantic hemi loss, particularly inferior quadrantic loss, while in this case you will have a superior quadrantic loss. So that will be very typical, quadrantic loss of homonymous hemianopia. So in general now together, so total left middle cerebral artery, this is superior branch, this is inferior branch, this is entire right superior and inferior together now. That is in inferior they have still mentioned this. There is something wrong in this. Sorry. Just you can go through at your leisure time and I'll reconfirm. It is definitely superior branch is Wernicke's area, inferior branch is Broca's area. So ICA, monocular blindness. ICA will produce MCA plus ACA territory, and unpaired anterior cerebral artery will produce paraplegia. Anterior cerebral artery will produce contralateral. Lower limb will be more involved as compared to upper limb. Opposite side. and lower limb will be mainly involved. In case of a posterior cerebral artery infarct, homonymous hemianopia with macular sparing, very typical. Watershed infarcts will produce hypoperfusion, will be the most common cause, particularly shock stage, and it will result into border zone area or watershed areas between AC and MCA territory, and it will be almost like man in a barrel, or we call global loss of blood flow, hemorrhagic shock, cardiac arrhythmia, septicemia, even in narcotic overdose. So this will be the watershed areas. This will be one watershed areas between anterior cerebral artery and middle cerebral artery. And whenever you get a damage, this area will be damaged. So that will be very, very typical. So these are the common conditions: watershed areas, narcotic overdose, hypotension. And there will be death of a tissue because of lack of blood supply in that watershed areas. This will be watershed areas. So there will be damage to those areas. And you will get typical finding in that watershed areas. Lacunar strokes will be small artery or penetrating branch which supplies basal ganglia, internal capsule and thalamus. Those are the branches of mainly middle cerebral artery. And that will give rise to lower limb and upper limb involved. And if there is an involvement of the subthalamic nucleus, you will get a hemibellismus. We already mentioned that internal capsule will produce pure motor findings, means hemiplegia, dense hemiplegia, and both will be equally involved. Plus, person can have even hemi-anesthesia because of thalamic fibers or thalamic radiation getting involved, and even involvement of the thalamus. So, person will have a peculiar finding, and very commonly they are chronic hypertensive patients. Lenticulostriate arteries are very commonly involved, and person will have an involvement of internal capsule, thalamus or subthalamic nucleus, and depending upon the involvement, person will have a characteristic findings. So lenticulostriate artery is involved. You will have face, arm and leg getting involved of opposite side. Motor function is involved. Plus, you might have even sensory loss. So it is both combined together involvement. So you will have dense hemiplegia with hemisensory loss, that is hemianesthesia. So it will be internal capsule involvement, and internal capsule is a compact fiber of corticospinal tracts and corticobulbar tracts. That will be all fibers going down will be involved. So it will be a dense hemiplegia with hemianesthesia. Somatosensory loss also because of involvement of thalamus and also thalamocortical fibers which are present in internal capsule. So that will be also involved. And if thalamus is involved, person can have post-thalamic pain radiation. That will be thalamic pains. It is also described as thalamic pains. So that can be a part of thalamus involved. So person will have allodynia, and thalamus is a center for sensory realization. You can have a microaneurysm rupture where you can get complete contralateral hemiparesis, hemisensory loss, and because this is in the deeper part, there will be no aphasia and brainstem is not involved, so there is no cranial nerve deficits. except you will have a upper motor neuron type of facial and upper motor neuron type of genioglossus involvement. So you can have a rupture of this aneurysm called Charcot-Bouchard's aneurysms, which can rupture, and you can see this. This is a hemorrhage which has taken place. So complete contralateral hemiparesis or hemiplegia with hemisensory loss, no cortical findings like aphasia, agnosia, etc., and no cranial nerve palsy. That will be very, very typical. But because of damage to the internal capsule, you will have upper motor neuron facial and you will have typical what we call as genioglossus involvement of opposite side. When subthalamic nucleus is involved, it will be contralateral hemibalismus. You will have a sudden jerky movement of one side. Lacunar infarcts, we have already mentioned. You will have together findings, pure motor, pure sensory. If only thalamus is involved, pure sensory. Internal capsule purely involved, pure motor. And when both are involved, you will have a sensory plus motor. And plus, you can have a thalamic pain syndromes also because of involvement of thalamus. And when subthalamic nucleus is involved, you will get hemibalismus. Now, regarding treatment part, there are few goals which you have to achieve. One, treatment of the general condition that needs to be stabilized. One part, specific therapy directed against the particular aspect of the stroke pathogenesis, say like embolic stroke, thrombosis, etc., or in case of a hemorrhagic stroke. Then prophylaxis and treatment of complication which may be either neurological or medical, early secondary prevention, and early rehabilitation. These are the different goals you will have to achieve, or 5 mainstays. Now, you want to re-establish the blood flow, particularly in case of thrombosis and embolism. Goal has to be achieved within 60 minutes for door to TPA administration. So for thrombolysis, TPA is being utilized. And for prevention of more clots, you will have to give aspirin. And you might require a surgical intervention in case of a thrombus which is not being lysed by TPA. You will require to remove mechanical embolus removal called MERCI, mechanical embolus removal in cerebral ischemia, MERCI, or suction removal. So you remove by fragments with suction. This is one of the technology which can be utilized. You can have a 5 steps: immediate workup, acute treatment, assess for etiology, then later on you can go for physiotherapy, occupational therapy, and speech therapy, and consider secondary prevention. As far as TPA is concerned, it has to be given only in case of ischemic stroke. It is absolutely contraindication in a person who has got hemorrhagic stroke. And if a person has got any clinical evidence of recent surgery, recent MI, or person has got bleeding disorders, in all those conditions, TPA is contraindicated. So absolute contraindication, ischemic stroke, head trauma, or neurosurgery within previous 3 months, intracranial hemorrhage, active internal bleeding, intracranial neoplasm, AV malformation or aneurysm, or if a blood pressure is more than 185, diastolic more than 110, platelet count less than 100,000 or we call 1 lakh, person is on anticoagulations, if the person has got already arterial puncture at non-compressible sites within past 7 days, etc., are absolute contraindications. There are many more. And onset of symptoms less than 4.5 hours prior to intravenous TPA administration unless the age is more than 80 or other less common features are present, in which case onset must be less than 3 hours. These are some of the parameters which should be considered for TPA administration. So indirectly, after estimating rapidly, we call as be fast. So if any person who has got an imbalance, eye, visual disturbances, facial weakness, arms and leg weakness, speech disturbances, and if the person comes in time, so door to physician evaluation 10 minutes, door to CT scan 20 minutes, door to CT head interpretation 45 minutes, so totally this should be within 45 minutes, and then you should immediately start door to TPA administration within 60 minutes and complete door to admission within 180 minutes. So these are all the parameters, but extremely difficult in any situations. By and large, they come after many hours rather than hour. So for TIA and stroke management, stroke or TIA, initially stabilize the person. You can give glucose to rule out hypoglycemia. Obtain CT scan without contrast. If it is hemorrhage, consider blood pressure lowering, because by and large it can be subarachnoid hemorrhage or intracranial hemorrhage, and accordingly in an aneurysmal subarachnoid hemorrhage you can go for a coil or a clip. In case of a hypertensive intracranial hemorrhage, you might require surgical intervention, and if it is because of some other causes, you can treat accordingly. While in case of an ischemic stroke, diagnosed after CT without contrast, consider thrombolysis or thrombectomy, particularly in case of an atrial fibrillation followed by an anticoagulation. In carotid artery disease, you can go for endarterectomy or stenting, and depending upon the etiology, you can go for specific treatment. In a DVT, you might have to treat simultaneously treatment for deep vein thrombosis also, and start treatment for secondary prevention. So after stabilization, which persons are included, which persons are excluded, and then after CT reports, what you undergo is mentioned clearly here. So once you make the diagnosis of CT stroke and you have got CT scan, then you can decide regarding what to do, which we have already mentioned before. You can go at your leisure time. This is a very simple way. You know that these are all the risk factors. These are reversible risk factors, these are non-reversible, and these are partially reversible, which you try to, all these factors should be avoided. Smoking, salt intake, sedentary lifestyle, stress, etc. Alcohol, all those should be reduced and avoided. Have a rigid control of blood pressure, control of arrhythmias, diabetes mellitus, and hyperlipidemia. These are also reversible. But non-reversible, we cannot do anything. So in a TIA, first assessment, and after assessing, if it is TIA, by and large we require to treat them rigidly to prevent a stroke. Once a person comes with a stroke, you require a neuro examination, CT, and only if you suspect hemorrhagic, you can go for a lumbar puncture. And in that, first you will require to stabilize the person, reduce intracranial pressure, proper nutrition, rehabilitation, preservation of functions, and then physiotherapy, occupational therapy, and speech therapy that will be required. You will have to simultaneously look for atherosclerosis, thrombosis, embolism, or it is an intracranial hemorrhage, and depending upon that your treatment will be specified. So If person has got ischemic stroke, TPA is the answer. And for secondary prevention, aspirin, statins, you might go for the dual platelet therapy, etc. Or sometimes you might require even anticoagulations. While in case of a hemorrhagic stroke, lowering blood pressure, refer to neurosurgery for craniotomy or coil or clipping. And if a person has got ischemic stroke, you will have to find out whether it is cardioembolic. If it is atrial flutter fibrillation, you might require an anticoagulation with heparin bridge. And after getting a echo done, and if the person has got a mural thrombus, you will require an anticoagulations. And if a carotid artery shows atherosclerosis, 70%, 80% narrowing, if there is a severe narrowing, you might have to go for endarterectomy followed by stenting. And if person has got carotid occlusion less than 70% and person is almost asymptomatic, then you will have to treat with a rigid lipid lowering, dual platelet therapy, control of diabetes, control of hypertension, as well as regular follow-up should be done. So during acute treatment, stabilization, TPA, if he is receiving TPA, his blood pressure should be less than 185 and 110. If no TPA, your goal systolic blood pressure should be reduced in hypertensive emergencies. If medical treatment is necessary, IV medications like nicardipine or labetalol, etc. should be utilized. In an outpatient antihypertensive can be gradually restarted after 24 hours. If TPA is given, you can also utilize mechanical thrombectomy after 24 hours. Wait for 24 hours before starting aspirin. Otherwise, start aspirin immediately if you are planning for mechanical thrombectomy. So, during acute treatment in TIA, early carotid ultrasounds or imagination, and you can go for endarterectomy and stenting. In case of ischemic stroke, start with dual platelet, but aspirin should be given immediately for 14 days, and then clopidogrel may be added. You can give even proton pump inhibitors. In the case of a venous sinus thrombosis, anticoagulation. If there is severe occlusion and thrombus, mechanical thrombectomy. You can go even for thrombolysis by TPA. Statin is absolutely necessary to have a rigid control on lipids. In case of a hemorrhagic strokes, stop anticoagulants, stop antithrombotic drugs, lower blood pressure, particularly in case of intracranial hemorrhage, to a systolic blood pressure close to 140 by giving injectable nicardipine or labetalol. And then you can go for surgical intervention like hematoma removal or endovascular repair like coil and clippings, particularly for aneurysms. In a chronic long-term case, stabilization, glucose monitoring, blood pressure control in case of intracranial hemorrhage, eclampsia, hypertension, hypertensive emergency, temperature control, hydration and nutrition, and then rehabilitation, early mobilization, physiotherapy, speech therapy, as well as occupational therapy. These are all the things which should be done. For secondary prevention, hypertension control, hyperlipidemia control, diabetic control, antiplatelets, and anticoagulants, particularly in a person with atrial fibrillation or cardioembolic phenomena. Initiate the secondary stroke prevention by antiplatelet drugs. Aspirin, you may add dual platelets, that is aspirin with clopidogrel or aspirin with dipyridamole. In some cases, you do require anticoagulation, particularly in case of atrial flutter fibrillation and almost all cases of cardioembolic phenomena. Long-term hypertensive management and rigid control of diabetes, high statin therapy, smoking cessation, regular exercise, healthy BMI, and also have a regular follow-up. And you might require a carotid endarterectomy or stenting. Minimizing the risk factor like quit smoking, healthy blood pressure, normal LDL, we call it a rigid control of diabetes, and you might require a surgical intervention like carotid endarterectomy or stenting. These are all the things which you can go for. It is said that initial first 45 minutes management requires mechanical evacuation of clot with all these parameters: physician evaluation, vital data, CT scan. Then you can go for neurology consultation, ensure IV line, have a blood parameter particularly to rule out the bleeding disorders, and then you can go for mechanical evacuation of clot. In acute ischemic stroke, we already mentioned, you can go for TPA, and that has to be given no antithrombotic therapy for first 24 hours. And blood pressure goal should be less than 185 and diastolic less than 110. Do not use nifedipine or hydralazine, and blood glucose level should be less than 150. CT scans should be looked for if there is any worsening or in neurological status, and monitor for other complications, particularly intracranial bleed. Acute ischemic stroke management without TPA, that is, all patients should be monitored for at least 72 hours. They should receive aspirin, Plavix, or combination of aspirin with dipyridamole. Dual antiplatelet therapy will be increasing the bleeding risk. All patients should receive statin in full therapeutic dose, we call high statin therapy. Hypertension should be well controlled. Do not use nifedipine or hydralazine. And have a regular checkup if required. Repeat CT if there is a deterioration in neurological status. No antithrombotic therapy for 48 hours. If person has got an hemorrhagic stroke, blood pressure should be lower than 140/90. Blood sugar should be less than 150. All anticoagulants should be reversed. No use of nifedipine and hydralazine. And regular CT scan to find out the worsening in neurological status. Post-acute care, follow-up, maintenance of vital parameters, physical therapy for evaluation, physical therapy, occupational therapy, as well as rigid control of all risk factors, and occupational therapy, speech therapy, etc. should be started. And according to NIH SS score, you can decide regarding a discharge. So those should be all those things. And these are what you get in a recovery. It is called Brunstrom approach. Initially during acute stroke, there will be no voluntary movements. Then there will be beginning of spasticity. Then you will have a marked spasticity, movement in synergies, muscles. Out of synergies, less spasticity, isolated joint movements, and then you will get a normal motor function restored. And depending upon that, you will be planned out for what we call as a physiotherapy, occupational therapy. That will be done during recovery phase. And You can also go for a speech therapy. Person has developed aphasia. As far as complication is concerned, because of a infarct, you can have a permanent neurological disability. You can get secondary seizures, and because of that disability, person can have a fall. Person can develop raised intracranial pressure and complication because of raised intracranial pressure. During a bedridden position, pneumonia, bad sores, UTI, hypothermia are quite common. Aspiration pneumonia, DVT, pulmonary embolism, hypoxia, constipations, hyponatremia, hypoglycemia, dehydration. These are some of the things which can happen during a hospitalization. Person can develop a psychiatric problem in the form of depressions, bad sores, frozen shoulders. Person can have irreversible damage to the brainstem, and person can go into what we call as a locked-in syndrome, or because of a very bad damage to the cortex, person can go into a stage where we call vegetative stage, and in the end person can die. These are all the different complications which can occur. So I end my lecture here. I feel this portion will be also helpful to you in your everyday practice as well as in your oral exam, in your theory. If you like this particular lecture, please don't forget to share with your friends, press like button, subscribe, and don't forget to place bell icon so you can get a message next time when I upload the video. So at the end, thank you very much for taking out time. I know that your time is valuable, and I also appreciate you have spent some of the time with me. See you in next lecture.